Assalamu alaikum. Thank you for coming. Thank you, Dr. Azza, for your comprehensive review of management of hyperkalemia. Thank you so much for being with us today. Today, I'm going to discuss quickly new updates about the management of lupus nephritis that's recently published by the KDIGO guidelines in 2023. Actually, we all know that lupus is a systemic disease affecting nearly all organ systems of the body. And here we are concerned with the renal involvement in systemic lupus. Management of this disease is very complex, and renal presentation is usually in the form of proteinuria, hematuria, presence of RBCs cast, reduction of GFR, and progressive impairment of kidney function. And usually the manifestations of lupus are diverse, especially lupus nephritis, and the main presentation or the most common presentation we see in the urine analysis, which is a very important tool to diagnose renal involvement in systemic lupus, is a proteinuria, presence of microscopic hematuria, and RBCs cast in urine analysis. And actually these three manifestations or findings in the urine analysis is very important to highlight, because it's in the SLE disease activity index that's used to stage the degree of activity or the severity of the active disease in lupus patients. Every one of these items, proteinuria, hematuria, or RBCs, counts as 4 points in this SLE disease activity index. So only these 3 points count as 12 points in the SLE disease activity index. And we know that this activity index ranging from 0 to 25, and the higher the score, the higher the activity index. So only these 3 points count as 12 points. These 3 findings in urine analysis are considered as 12 points in the activity index, so denoting a severe disease or denoting a very active disease, and should be taken seriously in any patient with lupus. And as we know that lupus with time will progress to end-stage kidney disease, and if we compare this comprehensive or review of the progressive nephron loss in normal population, the blue line, this is showing the progressive loss of the nephron mass with age, and this is the normal physiologic change. And if we see as nearly at the age of 70, most of the patients or most of the healthy person, having a GFR around 70, which nearly a stage is within the CKD stage 2. But this is the physiologic change, and this is the not physiological, but aging process, including the progressive nephron loss. But if we compare that with patients who are having lupus with single attack of lupus activity, there is a progressive nephron loss and reduction of GFR. And if the patient achieve at the end of this episode of lupus nephritis, achieve complete remission, even his progression in the higher red line will show also a progressive nephron loss. But at the age of 70, the GFR will be around 30 or 35 milliliter per minute, compared to 70 in a person who is healthy at the same age group. But if a patient getting more and more lupus flares with lupus nephritis, his progressive nephron loss will be so rapid, so he reach an end-stage kidney disease at the age of 45 to 50 years of age. Regarding mortality in patient with systemic lupus or patient in lupus with lupus nephritis or without lupus nephritis. Patient with lupus nephritis having a higher mortality rate, especially in the younger age group and the elder age group. But in the middle age group, patient with lupus nephritis or without lupus nephritis having the same mortality rate compared to each other. and the highest mortality rate among patients with lupus in the youngest age group who are having active lupus nephritis, as we see in the first graph. So the treatment goal for lupus nephritis is mainly to achieve rapid remission of the active disease and prevent renal losses or renal flares in the future. So achieving remission and preventing renal flares is very important to prevent long-term loss of kidney function and to preserve the kidney function as much as possible. And this will be reflected in improving kidney disease-related quality of life, preventing organ damage, improve quality of life, patient survival will be improved, and less morbidity and mortality, and minimize treatment-associated toxicity because this patient will be less exposed to immunosuppressive medication in the future if renal flare is prevented by active management. And how to achieve remission in patients with lupus nephritis? It's very important that the most important point is the urine protein excretion or degree of proteinuria. And it's always defined that protein excretion less than 0.5 gram per day is a marker of remission, and this important marker for good long-term outcome. But in two other trials, the Euro lupus nephritis trial and maintain trials, they define different level or cutoff level of proteinuria as less than 0.8 gram per day as the best predictor of long-term outcome, while in maintain nephritis trial defined a 0.7 or less grams of protein in urine is the best predicted good long-term renal outcome. But the KDIGO defined remission is defined as proteinuria less than 0.5 gram per day. So the most recent and recently published lupus nephritis management from KDIGO, they classified the treatment according to the degree of histopathological classification of lupus nephritis. And they defined the class 1, class 2 as probably the less benign or the benign one of classes of lupus nephritis, which is minimal mesangial lupus nephritis or mesangial proliferative lupus nephritis. That's class 1 and class 2. While the most aggressive and having the worst prognosis is the focal lupus nephritis as class 3, diffuse proliferative lupus nephritis as class 4, and lupus membranous nephropathy as class 5. And these three classes are the most dangerous and needs early intervention and rapid aggressive treatment. While stage 6 is advanced sclerosing lupus nephropathy, which is an end-stage renal disease at which the patient will require renal replacement therapy. Patient in this stage of lupus nephropathy, according to their histologic classification, having separate treatment lines accordingly. But they emphasize that there are general measures to be implemented for all classes of lupus nephritis. That's main target is to minimize the risk of complication related to lupus nephritis itself or its treatment. And of these risk factors that need to be controlled is a cardiovascular risk reduction by lifestyle modification and management of dyslipidemia and using low-dose aspirin during pregnancy. Proteinuria management by avoiding high salt diet, proper blood pressure control, especially by using RAS blockade, and infection risk management or reduction by proper vaccination and screening for associated viral infections like hepatitis B, C, HIV, and also enhanced vaccination for herpes zoster vaccine. And also one of the important risks to be managed in general for patients with lupus is a bone injury. Bone mineral density and fracture risk assessment should be implemented for all patients, and calcium vitamin D supplements should be provided for patients having a long-term use of oral steroid. Bisphosphonates should be also implemented for patients having a BMD indicating degree of osteoporosis, especially in older age females. Reducing ultraviolet exposure by using broad-spectrum sunscreens and limiting the exposure to ultraviolet is important for skin protection. Premature ovarian failure is one of the important targets for the young age females. Using gonadotropin-releasing hormone antagonists and also sperm or oocyte cryopreservation for patients who are going to have cyclophosphamide. Unplanned pregnancy should be avoided and should be counseled properly with nephrologists and gynecologists to prevent or to plan pregnancy according to the activity status of the disease course. Cancer screening also very important, especially for patients who are receiving long-term immunosuppression, especially high doses of cyclophosphamide. So treatment of class 1 or class 2 of lupus nephritis based on the kidney biopsy and also on the urine protein excretion per day. If the patient is having a low level of protein less than 1 gram per day, it should be monitored properly, closely, and using less immunosuppressive medication unless steroid can be implemented if the patient having extrarenal manifestation. But if the patient is having nephrotic range of proteinuria and having picture of nephrotic syndrome, so lupus activity should be evaluated, and if the biopsy showing extensive podocyte involvement, podocyte damage, patient should be treated with combination of steroids plus immunosuppressive medication. 3 and class 4 are very important. This is the aggressive type, and it should be treated properly early in the course of the disease, and treatment using combined treatment with oral steroids plus other immunosuppressive. Glucocorticoids is very important to be started by pulse steroid, followed by long-term maintenance of oral steroids, together with immunosuppression either by mycophenolic acid analogs or intravenous cyclophosphamide in low doses for short period of time. This is the standard therapy, but also some patients are having frequent relapse or having severe aggressive disease according to the biopsy with activity index, high activity index in the kidney biopsy. A third agent, in addition to glucocorticoids or MPA or cyclophosphamide, a third agent can be added like belimumab. Belimumab is a monoclonal antibody which is newly introduced in the course of treatment management for lupus nephritis, and it helps in reducing remission inducing remission and reducing relapse of lupus nephritis. And belimumab can be combined with either MPA or short course or low dose intravenous cyclophosphamide. But again, the problem with this combination is the risk of high immunosuppression and risk of infection, and patient should be monitored properly with reducing the risk of infection as much as we can. Another protocol to have a triple immunosuppression is combining MPA plus calcineurin inhibitors in patients with normal kidney function test and having estimated GFR more than 45 milliliter per minute. It is safe to combine glucocorticoids with MPA and cycloneurin inhibitors. So patients with active lupus class 3 or class 4 should be properly managed, aggressively managed, and early introduction of treatment protocol is important to prevent progressive damage of the kidney. Steroid protocols, they recommended 3 steroid protocols, either standard dose, moderate dose, or reduced dose. All are starting with initial pulse methylprednisolone, that's solumedrol, using 250 to 500 milligram every day for 3 to 5 days, according to the severity of the disease. Then gradual tapering down to 25 months, nearly 6 months. Patient should be maintained on these steroids without stopping of oral steroid. Patients who are achieving remission after this course of steroid together with immunosuppressive medication should continue the treatment with oral steroids. The minimum acceptable dose or minimum tolerated dose should be continued for at least 12 months after achieving complete remission. So steroid should not be stopped at least 12 months after achieving complete remission. After initial treatment and induction of remission, which usually takes 6 to 12 months to be achieved after starting treatment with combined steroid and immunosuppression, then the patient, if he achieves achieving the complete remission or partial remission, then he should be continued on maintenance therapy using the first line recommended is MPA as a first line management for maintenance therapy for class 3 and class 4 lupus nephritis. And they emphasize that the combined period of initial treatment and maintenance therapy should not be less than 36 months of treatment. So patient should be maintained for 3 years at least on combined low-dose steroid and immunosuppression, but steroid can be stopped 12 months after achieving complete remission, and the patient will continue the 3 years on MPA as a first-line recommended therapy for maintenance until the patient complete total of 36 months. Other immunosuppressive agents recommended to be used for maintenance therapy after achieving complete remission. First one, as we just mentioned, is the mycophenolate, which is a preferred treatment for lupus nephritis as a maintenance therapy and to complete 36 months, as we just mentioned. Another alternative is azathioprine, which is another medication that should be or can be used during the maintenance period for maintaining remission of lupus nephritis. It's a low-cost medication, that's its advantage, and the safe medicine to be used during pregnancy for patients with lupus nephritis. Another protocol also suggested to be used for maintenance therapy using combined belimumab and MPA or azathioprine. So combining belimumab with MPA or belimumab with azathioprine is a third line of treatment for maintenance immunosuppression in patients who achieved complete or partial remission in lupus nephritis. Combining mycophenolate with CNI is also a protocol can be implemented for patients who are having a complete remission or partial remission with a GFR of more than 45 milliliter per minute with close monitoring of kidney function test. And the newly introduced CMI, the cephalosporin, can also be used, but its safety in pregnancy still questionable and cannot be used in pregnancy. While tacrolimus and cyclosporin can be used safely in pregnancy for maintaining remission in patients with lupus nephritis. So different protocols for maintenance, but the standard is or the most recommended protocol is MPA for complete 36 months and the steroid for the initial therapy together with 12 months from the maintenance period. Class 5 lupus nephritis also, if it is alone as isolated class 5 lupus nephritis membranous nephropathy, or if it is combined with class 3 or class 4, sometimes we find the kidney biopsy showing combined proliferative lupus in addition to membranous nephropathy, and these patients should be treated aggressively also as isolated class 3 or class 4. But isolated class 5 depends also on the degree of proteinuria. If the degree of proteinuria is less than nephrotic range or less than 1 gram per day, patients should be monitored closely with tight control of blood pressure, implementing RAS blockade, and immunosuppressive medication is only indicated if the patient having extrarenal symptoms necessitating use of immunosuppression. This is in addition to use of hydroxychloroquine. If the patient is having nephrotic syndrome, nephrotic range proteinuria, more than 3.5 grams per day, RAS blockade is recommended protocol for controlling blood pressure and reduction of proteinuria, together with combined immunosuppression with oral glucocorticoids. Initially, patients have induction with methylprednisolone, then continue oral steroids for long term as in class 3 or class 4. Other agents can be used as immunosuppressive agent, MPA, azathioprine, cyclophosphamide, CNI, rituximab. All these are alternative immunosuppressive agent combined with glucocorticoids. Hydroxychloroquine is mandatory to be introduced in patients with lupus nephritis. So after starting treatment, patients should be assessed on a monthly basis, and how to define that the patient having remission of the active lupus nephritis. There are different 3 grades of response, either complete response if the patient achieves UPCR less than 0.5 gram per day, or stabilizing of kidney function within a range between 10 to 15% plus or minus the baseline before starting treatment. If this patient achieves these parameters within 6 to 12 months of initiation of treatment, this is called complete response or complete remission, after which the patient can start going for the maintenance therapy. Partial response is defined as reduction of proteinuria by 50% from the initial baseline and urine protein creatinine ratio less than 3 grams per gram. And this is in addition to stable kidney function test with a GFR 10 to 15% plus or minus the baseline GFR. And this also after 6 to 12 months of initiation of treatment. If patient is not achieving either complete or partial remission within 6 to 12 months of initial treatment protocol, this is called non-responder and no response, and this patient should be re-evaluated. Why he is not responding to treatment, either complete remission or partial remission. Management of this unsatisfactory response or resistance to treatment, we have to review if the patient is adherent to his treatment protocol. Some patients are not adherent to treatment because of side effects of treatments. Some patients are not tolerating MPA. We usually start MPA with steroids for patients with lupus nephritis, but patients sometimes get GI side effects and they're non-adherent for treatment. These patients should be shifted to IV cyclophosphamide for short term to avoid this non-adherence problem. The other thing is a plasma drug level. Some medicine should be monitored for drug level like MPA or CNIs to make sure that the patient is getting the proper dose and getting the proper drug level to induce remission and get the patient reaching that stage of complete remission or partial remission. Or repeat biopsy. Sometimes we might repeat biopsy. Sometimes patient will progress from one stage to another, either class 2, progressing to class 3 or class 4. Class 3 or class 4 could be progressed to combined 3 or 4 plus membranous nephropathy. So sometimes we need to revise the treatment according to the new biopsy. Or we can consider alternate initial first-line regimen instead of using the initial protocol with steroid and MPA. If the patient is not responding, we can shift the patient to another first-line management like steroids and short-term cyclophosphamide, or the reverse. Or we can also, if the patient is receiving these two medicine as an initial protocol, we can add on a third agent as an initial treatment with steroid and MPA. We can add rituximab or change cyclophosphamide from the low dose protocol to the high dose extended protocol of cyclophosphamide. If the patient achieving complete or partial remission and kept on maintenance therapy, and while he is maintenance protocol, he achieved or he develops a relapse of lupus nephritis, that will be evident by the increasing of the urine protein excretion, rising of creatinine, presence of active urine sediment. This patient should be treated as initial treatment protocol. Again, if he achieved complete remission with steroid and MPA, and he developed relapse after 2 or 3 years, so we can go back to the initial protocol, the same protocol, or we can shift to another protocol if the initial protocol didn't show complete remission response. The problem if the patient gets pregnant during the course of treatment with lupus nephritis, and we emphasized at the start as a general protocol, avoid unplanned pregnancy during the course of treatment. Because pregnancy should be avoided in any patient who having active disease or using any teratogenic medicine, especially that MPA is teratogenic and contraindicated with pregnancy. Any female who is going to get pregnant or planning to get pregnant should be at least in inactive state for at least 6 months. Otherwise, patients might have flare-up of lupus again or will be exposed to the teratogenic effect to MPA. And to reduce the risk of pregnancy complication, hydroxychloroquine should be induced as early as possible during pregnancy, in the first trimester of pregnancy, together with aspirin in low dose during the first trimester of pregnancy. And the only medication that's approved to be used during pregnancy for induction of remission or treatment of lupus during pregnancy is a glucocorticoid, hydroxychloroquine, azathioprine, tacrolimus, and cyclosporin. These are safe medicines that could be used during pregnancy. Sometimes we have patient who is achieving remission and kept for more than 6 months in remission, and now she gets pregnant, and during pregnancy, sometimes they develop flare-up of lupus during pregnancy. At this stage, we can introduce glucocorticoids in high doses again, use cyclosporin or tacrolimus during pregnancy is safe to induce remission while the patient is pregnant. But MPA, cyclophosphamide are contraindicated. Glimumab, there is no significant studies to be implemented during pregnancy. And also voclosporin is not yet studied for pregnant ladies. Management of lupus with kidney failure. When the patient of lupus reach end-stage renal disease, the available options for replacement, either hemodialysis or peritoneal dialysis, but kidney transplant is usually the preferred treatment as long-term for such patient. Remission can, or relapse of lupus and recurrence of the primary disease in the transplanted kidney can happen, but as we know that the treatment of lupus is part of the immunosuppressive protocol for patients with kidney transplant who are using usually steroid, MPA, and cyclosporin. In these stages, if the patient develops any remission or relapse of the primary disease in the transplanted kidney, usually we augment the immunosuppressive medication during the course of the disease until achieving complete remission again, and the patient will continue with stable kidney function test. Thank you.